Hello everyone, I'm Dr. Manvi Gupta and today we are going to talk about high altitude and deep sea physiology. Now these two scenarios might seem worlds apart from each other, but I think by the end of this lecture you will be amazed to see so many similarities that the body experiences under these two seemingly opposite situations. So let's begin. What are the learning objectives for today? So we are going to learn about the effects of decreased barometric pressure, then what is mountain sickness, acclimatization, and then the effects of increased barometric pressure, decompression sickness, and finally scuba diving. So first let's start with understanding that what is it that we call high altitude. High altitude is a height in excess of 10,000 feet, that is 3,000 meters above sea level. Now, if you look at the chart on the left, you can see that at 10,000 feet, usually there are no symptoms or some degree of hypoxia may be present, but the body can easily acclimatize to the oxygen lack. Now, the highest altitude at which permanent habitation is possible is around 18,000 feet. Above an altitude of 20,000 feet, hypoxia can endanger life unless oxygen is added to the inhaled air. The modern aircrafts usually fly at an altitude of about 35,000 feet. The use of pressurized cabins in these aircrafts help to provide an environment similar to that at sea level. And the ozone layer starts at above an altitude of 40,000 feet. Now looking at the figure on the right, you can observe that in unacclimatized subjects, mental symptoms such as irritability appear at about 3,700 meters. At 5,500 meters, hypoxic symptoms are severe. And at altitudes above 6,100 meters, consciousness is usually lost. At about 14,000 meters, consciousness is lost in spite of administration of 100% oxygen. At 19,200 meters, the barometric pressure is 47 mm of Hg. And at or below this pressure, the body fluids boil at body temperature. This point is largely academic. However, because any individual exposed to such a low pressure would be dead of hypoxia before the bubbles of steam could actually cause death. Now, the barometric pressure is inversely proportional to altitude, which means that it progressively falls with increasing height. So as you can see on this slide, the barometric pressure at sea level is 760 mm Hg. At 10,000 feet, it is 523 mm Hg, and at 50,000 feet, it is merely 87 mm Hg. However, the composition of air remains constant from sea level to about 30,000 feet. Another property about barometric pressure is that it is proportional to the partial pressure of oxygen. With decrease in total pressure of air at increasing altitude, partial pressure of gases will change. We know that because of Dalton's law, which states that the total pressure of air is equal to sum of partial pressures of gases contained in it. Thus, the total pressure of air would be equal to partial pressure of oxygen plus partial pressure of carbon dioxide plus partial pressure of nitrogen and partial pressure of water vapor. Now, as you can see in these tables, the partial pressure of water vapor does not depend on high altitude because it is entirely determined by the body temperature. As the body can regulate its temperature at 37 degrees Celsius, irrespective of altitude, therefore, the partial pressure of water vapor remains constant at 47 mm Hg. Alveolar partial pressure of carbon dioxide depends upon the balance between metabolism of body and respiration. Therefore, when body metabolism increases, alveolar PCO2 increases causing pulmonary ventilation to increase. Carbon dioxide gets washed out, thereby restoring alveolar PCO2. And opposite is seen when body metabolism decreases. Now, as the metabolic production of carbon dioxide doesn't alter with increasing altitude, alveolar PCO2 will not change until breathing is affected by some other cause, example by hypoxia. So I hope by now it is clear that with increasing altitude, barometric pressure decreases, so total pressure of the air decreases. As the partial pressure of water vapor and carbon dioxide remains constant, therefore, there occurs progressive decrease in pressure of oxygen and that of nitrogen with increase of height. As decrease in pressure of nitrogen produces no effects on the body, therefore, effects of high altitude are entirely due to decrease in PO2 in inspired air. That is, the effects are same as hypoxic hypoxia. Now, if you recall from our previous lecture, hypoxic hypoxia is a condition of reduced arterial PO2. It is a problem in normal individuals at high altitude and also a complication of pneumonia and variety of other diseases of the respiratory system. Here in this table, you can see some features of hypoxic hypoxia at high altitude. So when the type of ascent is rapid, the degree of hypoxia is severe. There is no compensatory mechanism that the body has in such a case, and the effects of hypoxia will therefore be severe. In case of a slow ascent, the degree of hypoxia will be less. There are some compensatory mechanisms that the body has, and therefore the effects of hypoxia will be moderate. In case of high altitude natives, degree of hypoxia is least because their body has well developed compensatory mechanisms, and thus the effects of hypoxia will be nil due to the process of acclimatization in them. Now, hypoxic hypoxia produced by decreased PO2 at high altitude depends on the following: the level of altitude, the rate at which hypoxia develops, whether the onset is sudden, as in case of rapid ascent, or gradual, as in case of slow ascent. And thirdly, it depends on the duration of exposure, whether it is long term, as in case of permanent residence at high altitudes, or if it's short term. Now here is a table showing you effects of high altitude during rapid ascent. So we know that at sea level, the barometric pressure is about 760 mmHg, inspired PO2 is 160, alveolar PO2 is 100 to 104, alveolar PCO2 is about 40 mmHg, and percentage oxygen saturation of hemoglobin is 100%. So definitely there is no hypoxia at sea level. Now up to 5,000 feet, the barometric pressure decreases to 630, inspired air PO2 goes down to 128, alveolar PO2 goes down to 80, and alveolar PCO2 remains same at 40 mmHg. The percentage oxygen saturation of hemoglobin decreases to 95%. So no effects till alveolar PO2 is still more than 60 mmHg, with normal alveolar PCO2 being 40 mmHg. Now up to 10,000 feet, the barometric pressure further decreases to 520 mmHg. Inspired air PO2 reduces to 104, alveolar PO2 reduces to 60, alveolar PCO2 is still the same at 40 mmHg, and percentage oxygen saturation of hemoglobin decreases to 89%. So usually at this stage there are no effects except at night when there is reduction in visual capacity. Hence, rapid ascent up to 10,000 feet is the safe zone of ascent. Now up to 12,000 feet, the barometric pressure reduces to 490, inspired air PO2 reduces to 98, alveolar PO2 reduces to 55, and this time alveolar PCO2 also reduces slightly less than 40 mm of Hg. Percentage oxygen saturation of hemoglobin decreases to 85%. So at this stage, hypoxia does manifest, but as tachycardia, hypertension, and increased pulmonary ventilation. Now, up to 18,000 feet, the barometric pressure reduces to 400 mmHg, inspired PO2 up to 80, alveolar PO2 reduces to 40, alveolar PCO2 also reduces up to 30 mm of Hg, and percentage oxygen saturation of hemoglobin reduces to 70%. So at this stage, the above hypoxic changes are there, plus symptoms due to CNS involvement also appear. Now, up to 20,000 feet, barometric pressure further reduces to 350, inspired PO2 reduces to 70, alveolar PO2 becomes less than 40, alveolar PCO2 becomes less than 30 mm of Hg, and percentage oxygen saturation of hemoglobin reduces to 70%. So at this stage, hypoxic symptoms are there due to CNS involvement. If oxygen percentage saturation of hemoglobin decreases to less than 60%, then the person will suffer from unconsciousness. Now, between 25,000 to 30,000 feet, there is further decrease in all these values. And also, the percentage oxygen saturation of hemoglobin decreases to less than 60%. Now, beyond this stage, oxygen therapy has to be started. Hence, this is called as critical survival altitude. Now, with 100% oxygen inhalation, one can go till 45,000 feet, at which the barometric pressure reduces to 110 mm of Hg. Now, this pressure has to accommodate the partial pressure of water vapor, which is about 47 mm of Hg, and that of carbon dioxide, which is about 30 mm of Hg. Hence, PO2 left within the barometric pressure of 110 minus sum of 47 plus 30 would be 33 mm of Hg. Now, when this PO2 reduces to 40 mm of Hg, then there will be impairment of mental functions. At approximately 63,000 feet, the barometric pressure reduces to 47 mm Hg, and water will occupy all the pressure. Hence, body fluids will boil at body temperature, which is a theoretical concept. Thus, more than 40 to 45,000 feet, creation of artificial atmosphere in a pressurized cabin, such as in a spaceship, would be necessary, and in such a cabin, one can go up to any altitude. Now, what is mountain sickness? So, on first arrival at a high altitude, many individuals develop transient mountain sickness. It is of two types, acute and chronic, also known as Monge's disease. And there are certain clinical syndromes caused by rapid ascent to high altitude. They are high altitude pulmonary edema and high altitude cerebral edema. So these are the types of altitude sickness seen on rapid ascent. And now let's go on to learning about acute mountain sickness. So AMS refers to a symptom complex which occurs in an individual residing at sea level who ascends to a high altitude over a period of 1 to 2 days for the very first time. The symptoms start approximately 8 to 24 hours after arrival at high altitude and last for about 4 to 8 days. Characteristic features are nausea, vomiting, headache, insomnia, dyspnea, and irritability. Exact cause is not known but appears to be associated with cerebral edema or alkalosis. The low PO2 at high altitude causes arteriolar dilatation, and if cerebral autoregulation does not compensate, there is an increase in capillary pressure that favors increased transudation of fluid into brain tissue. Now, high altitude pulmonary edema is a condition that often develops when one is doing rapid ascent above 10,000 feet. It is a patchy edema of lungs that is related to marked pulmonary hypertension that develops at high altitude. It's been argued that it occurs because not all pulmonary arteries have enough smooth muscle to constrict in response to hypoxia. And in the capillaries supplied by those arteries, the general rise in pulmonary arterial pressure causes a capillary pressure increase that disrupts their wall, which is due to stress failure. It is seen in individuals who engage in heavy physical work during first 3 days after arrival, in those who are acclimatized to high altitudes but spend 2 or more weeks at sea level and then reascend. It is not due to cardiovascular or lung disease because it responds to rest and oxygen. And it does not develop in individuals who ascend to high altitude gradually and avoid physical exertion for the very few days of first high altitude exposure. Now, what is the mechanism? So, the causes are largely unknown. Probable causes are hypoxia. Hypoxia gets aggravated by work and can increase membrane permeability of pulmonary capillaries, producing pulmonary edema. Normally, pulmonary capillary hydrostatic pressure of less than 10 mmHg and osmotic pressure of 25 mmHg keep the alveoli dry. Now, at high altitude, sympathetic activity increases due to 1. Hypoxic stimulation of the vasomotor center, 2. Because of cold, and 3. Because of increased physical work. So, there is increased sympathetic activity, which leads to vasoconstriction. That causes increased pulmonary capillary hydrostatic pressure, which drives the fluid out of the pulmonary capillaries, producing pulmonary edema. Now, high altitude cerebral edema is another clinical syndrome precipitated by rapid ascent to high altitude. So, what is the mechanism in this case? The capillary leakage in mountain sickness progresses to frank brain swelling. Decrease in arterial PO2 with increasing altitude leads to arteriolar dilatation. Once the limit of cerebral circulation autoregulatory mechanism is reached, capillary pressure increases, causing transudation of fluid in the brain tissue. If not treated, it may cause ataxia, disorientation, coma, and finally death due to herniation of brain through the tentorium. Now, treatment. So, a basic thumb rule of preventing a high altitude illness is to climb high but sleep low. All forms of high altitude illnesses are benefited by descent to lower altitude and, if required, with treatment with a diuretic called as acetazolamide. Specifically, cerebral edema is reduced by administration of large doses of glucocorticoids or nifedipine, which is a calcium channel blocker. Pulmonary edema is reduced by administering a calcium channel blocker, for example, nifedipine, which reduces pulmonary arterial pressure. Also, prompt treatment with oxygen is essential, and if available, use of a hyperbaric chamber and hyperbaric portable chambers are now available in a number of mountain areas. Thirdly, respiratory alkalosis that results from hyperventilation is prevented by administering acetazolamide. This, by inhibiting carbonic anhydrase, decreases hydrogen ions and increases bicarbonate excretion through kidneys, thus stimulating respiration and decreasing formation of CSF. So this slide shows you a recap of all the characteristics of high altitude illnesses that we have just talked about. Now, we learned about what happens during rapid ascent, but what happens in case of slow ascent? So, effects of hypoxia are not very severe in case of slow ascent because the body gets adequate time to adjust to hypoxia. For example, in 1953, Edmund Hillary at the summit of Mount Everest, approximately 29,000 feet, could walk nicely for 10 minutes, after which he had to take oxygen. Now let's learn about chronic mountain sickness or Monge's disease. So CMS occurs in long-term residents of high altitude who develop extreme polycythemia, cyanosis, malaise, fatigue and exercise intolerance. Occasionally, a person who remains at high altitude for too long develops chronic mountain sickness, in which the following effects occur. The red cell mass and hematocrit become exceptionally high. The pulmonary arterial pressure becomes elevated even more than the normal elevation that occurs during acclimatization. The right side of the heart becomes greatly enlarged. The peripheral arterial pressure begins to fall. Congestive heart failure ensues, and death often follows unless the person is removed to a lower altitude. The causes of this sequence of events are probably threefold. First, the red cell mass becomes so great that the blood viscosity increases several fold. This increased viscosity tends to decrease tissue blood flow so that oxygen delivery also begins to decrease. Secondly, the pulmonary arterioles become vasoconstricted because of lung hypoxia. This results from hypoxic vascular constrictor effect that normally operates to divert blood flow from low oxygen to high oxygen alveoli. But because all the alveoli are now in the low oxygen state, all the arterioles become constricted, the pulmonary arterial pressure rises excessively, and the right side of the heart fails. Thirdly, the alveolar arteriolar spasm diverts much of the blood flow through the non-alveolar pulmonary vessels, thus causing an excess of pulmonary shunt blood flow, where the blood is poorly oxygenated, which further compounds the problem. These individuals must be removed to a lower altitude to prevent rapid development of fatal pulmonary edema. Most of these people recover within days or weeks when they are moved to a lower altitude. Now, two physiological compensatory mechanisms are known to occur in individuals exposed to high altitude hypoxia. One is accommodation and second is acclimatization. So, accommodation are the immediate reflex adjustments of the respiratory and cardiovascular systems to hypoxia. These include hyperventilation, tachycardia, and increased 2,3-DPG concentration in RBCs. Now, what is acclimatization? So, changes in body tissues in response to long term exposure to hypoxia constitute acclimatization. For example, when a person living at sea level goes and stays at high altitude for a long time. So, a person remaining at high altitude for days, weeks, or years becomes more and more acclimatized to the low PO2 so that it causes fewer deleterious effects on the body, and it becomes possible for the person to work harder without hypoxic effects or to ascend to still higher altitudes. Now, there are permanent residents in Himalayas, approximately at 18,000 feet, where PO2 is less than 40 mmHg, but they are leading a perfectly normal and prolonged life, all because of the process of acclimatization. So, which are the acclimatization mechanisms? Increased RBC count, increased pulmonary ventilation, some cardiovascular changes, pulmonary hypertension, increased total lung capacity and diffusing capacity, cellular and tissue acclimatization, and reduced respiratory drive. So, increased pulmonary ventilation occurs due to role of arterial chemoreceptors. Immediate exposure to low PO2 stimulates arterial chemoreceptors, and this increases alveolar ventilation to a maximum of 1.65 times the norm. Therefore, compensation occurs within seconds for high altitude, and it allows the person to rise several thousand feet higher than would be possible without the increased ventilation. Then, if the person remains at very high altitude for several days, the chemoreceptors increase ventilation still more, up to 5 times than normal. The immediate increase in pulmonary ventilation on rising to high altitude blows off large quantities of carbon dioxide, reducing PCO2 and increasing pH of body fluids. These changes inhibit brainstem respiratory center and thereby oppose effect of low PO2 to stimulate respiration by way of peripheral arterial chemoreceptors in the carotid and aortic bodies. But during the ensuing 2 to 5 days, this inhibition fades away, allowing the respiratory center to respond with full force to the peripheral chemoreceptor stimulus from hypoxia, and the ventilation increases to about 5 times normal. This cause of fading is believed to be mainly a reduction of bicarbonate ion concentration in CSF as well as brain tissue, which in turn decreases pH in the fluid surrounding the chemosensitive neurons of respiratory center, thus increasing the respiratory stimulatory activity of the center. An important mechanism for gradual decrease in bicarbonate ion concentration is the compensation done by kidneys for respiratory alkalosis. This is done by reducing hydrogen ion secretion and increasing bicarbonate excretion. The second mechanism is increased RBC count. So hypoxia is the principal stimulus for causing an increase in RBC cell production. So this polycythemia, second to tissue hypoxia, results from release of renal erythropoietic factor, which acts on plasma globulin to form erythropoietin. Erythropoietin stimulates production of RBCs from the bone marrow. Ordinarily, when a person remains exposed to low oxygen for weeks at a time, the hematocrit rises slowly from a normal value of 40 to 45 to an average of about 60, with an average increase in whole blood hemoglobin concentration from normal of 15 gram per deciliter to about 20 gram per deciliter. In addition, the blood volume also increases often by 20 to 30%, and increased blood hemoglobin concentration comes up to 50 or more percent. These changes allow each unit of blood to carry additional oxygen, which compensates for decreased oxygen tension. Increase in hemoglobin and blood volume start after 2 weeks, reaches half development in a month, and is fully developed only after many months. Now we know that normal diffusing capacity for oxygen through pulmonary membrane is about 21 ml per mmHg per minute, and this can increase as much as threefold during exercise. A similar increase in diffusing capacity occurs at high altitude. Part of the increase occurs from increased pulmonary capillary blood volume, which expands the capillaries and increases the surface area through which oxygen can diffuse into blood. Another part results from increase in lung air volume, which expands surface area of alveolar capillary interface still more. A final part results from increase in pulmonary arterial blood pressure, which forces blood into greater number of alveolar capillaries than normal, especially in upper parts of lungs which are poorly perfused under usual conditions. In natives, as compared to their sea level counterparts, increase in total lung capacity is evidenced by the enlarged chest that they develop. Cellular and tissue acclimatization occurs after a long stay at high altitude. This includes increase in oxidative enzyme concentrations within mitochondria of many tissues, which allows more rapid generation of ATP via oxidative phosphorylation. Secondly, there is increase in mitochondrial density within cells, which reduces diffusion distance and provides more sites for oxygen utilization. Thirdly, there is increase in capillary density in skeletal and cardiac muscles, which reduces diffusion difference from blood to the cells. This growth of increased number of systemic circulatory capillaries in non-pulmonary tissue is called as angiogenesis. Then decreased respiratory drive is caused by lifelong exposure to hypoxia for very prolonged periods. The reduced respiratory drive leads to higher carbon dioxide tension and lower oxygen tension, but it diminishes the work of respiration, which reserves more oxygen for the respiratory muscles. Pulmonary hypertension occurs secondary to generalized hypoxic pulmonary vasoconstriction. The increased pulmonary artery pressure causes even a more distribution of pulmonary blood flow, which can improve gas exchange. However, the elevated pulmonary artery pressure can induce cor pulmonale if the hypoxia is sufficiently severe. Then there are cardiovascular changes in form of increased heart rate, increased force of contraction, and increased cardiac output. The cardiac output often increases as much as 30% immediately after a person ascends to high altitude. that is in the initial accommodation period, but then decreases back towards normal over a period of weeks as the blood hematocrit increases, so that amount of oxygen transported to peripheral body tissues remains normal. The effectiveness of this acclimatization process is indicated by the fact that the human habitation exists in Andes and Himalayas at an elevation above 5,500 meters, and the natives who live in these villages are barrel-chested and markedly polycythemic. They have a ruddy complexion. They have low alveolar PO2 values, but in most other ways, they are remarkably normal. Now, what is adaptation? It is the genetic, non-reversible, inheritable form of adjustment in an individual who is often referred to as a high-altitude man. Many native human beings in Andes and Himalayas live above 13,000 feet. One group in Peruvian Andes lives at an altitude of 17,500 feet and works at a mine at an altitude of 19,000 feet. Many of these natives are born at these high altitudes and live there all their lives. In all aspects of acclimatization, the natives are superior to even the best acclimatized lowlander, even though the lowlanders might have lived at high altitudes for 10 or more years. Acclimatization of natives begins in infancy. The chest size, especially, is greatly increased, whereas body size is somewhat decreased, giving a high ratio of ventilatory capacity to body mass. In addition, their hearts, which from birth onward pump extra amounts of cardiac output, are considerably larger than those of lowlanders. You can see on the right in the diagram which shows oxygen hemoglobin dissociation curve for natives who live at sea level and for their counterparts who live at 15,000 feet. Note that the arterial oxygen PO2 in natives at high altitude is only 40 mmHg. But because of greater quantity of hemoglobin, the quantity of oxygen in the arterial blood is greater than that in blood of natives at lower altitude. Also note that the venous PO2 in high altitude natives is only 15 mmHg less than that of lowlanders, despite very low arterial PO2, indicating that oxygen transport to tissues is exceedingly effective in the naturally acclimatized high altitude native. We know that the work capacity of all muscles, not only skeletal but also cardiac muscle, is greatly decreased in hypoxia. In general, work capacity is reduced in direct proportion to decrease in maximum rate of oxygen uptake that the body can achieve. Thus, naturally acclimatized native people can achieve a daily work output even at high altitude, almost equal to that of lowlanders at sea level. But even well acclimatized lowlanders can almost never achieve this result. So this is a table that shows clear differences between high altitude natives and newcomers to high altitude. So in case of high altitude natives, their pulmonary ventilation is increased and therefore chest is enlarged, often barrel shaped, alveolar ventilation is increased and functional residual capacity is increased. Whereas in case of a newcomer to high altitude, pulmonary ventilation is decreased. Therefore, the chest size is smaller, alveolar ventilation is reduced, and reduced functional residual capacity is there. Now, in case of high altitude natives, they have hypocapnic alkalosis, which is reduced in their case. But in case of newcomers, the response to hypoxic stimulation is reduced. In case of high altitude natives, the urine reaction is alkaline, but in case of newcomers, it is acidic. Affinity of hemoglobin for oxygen is decreased in case of high altitude natives, so there is more oxygen released from hemoglobin. In case of newcomers, affinity is increased, so body tissue suffer from hypoxia. The RBC count in case of high altitude natives increases, therefore PCV increases, due to which they have red cheeks. But RBC count decreases in case of newcomers. Organ vascularity, mitochondria and myoglobin content of muscle, and diffusion capacity of lungs for oxygen All three factors increase in case of high altitude natives, whereas all three decrease in case of newcomers to high altitude. Now we learned all about the effects of decreased barometric pressure. But have you thought of the conditions in which the barometric pressure actually increases? What are those? So that occurs in case of deep sea diving, Caisson's workers, and in submarines. So deep sea diving, every 33 feet, there is increase of atmospheric pressure by 1 unit. In case of Caisson's workers, these are workers who are digging underwater tunnels in a chamber called as Caisson. And of course in submarines which go under the sea. The symptoms at high barometric pressure are experienced during exposure or upon sudden ascent. Now, what are the effects of high barometric pressure? So here you can see a depiction of the Boyle's law, which states that the volume of gases is inversely proportional to atmospheric pressure. So the atmospheric pressure increases, and that causes the partial pressure of oxygen, nitrogen and carbon dioxide to try to equalize pressure on the chest wall and abdomen. Now, some physiological problems can occur under depth of more than 30 meters due to mechanical effects of increased atmospheric pressure, such as caving in of chest, damage to the face, and squeezing of air in the paranasal sinuses and middle air. Now, some physiological problems arise due to effect of high barometric pressure. At this pressure, the partial pressure of oxygen, nitrogen and carbon dioxide is also increased, producing the following physiological problems. So, oxygen toxicity is one such problem. It may be acute or chronic. Acute oxygen toxicity occurs on exposure to 4 atmospheric pressure of oxygen. Acute oxygen poisoning is typically characterized by nervous system complications, as the brain tissue is especially susceptible to acute poisoning. At high tissue PO2, the molecular oxygen is converted into active oxygen, that is superoxide anion, which is a free radical. Nervous complications include disorientation, dizziness, convulsions, and even coma. Chronic oxygen toxicity occurs due to prolonged exposure of near about 8 to 24 hours to oxygen at 1 or 1.5 atmospheric pressure. And as we learned about oxygen toxicity symptoms in the last lecture, same symptoms happen in this case too, such as airways irritation, pulmonary edema, and bronchopneumonia. Then there can also occur carbon dioxide toxicity. So carbon dioxide builds up when the individual rebreathes carbon dioxide which is produced by the body. This happens in absence of an apparatus which absorbs carbon dioxide or releases expired carbon dioxide into the atmosphere. With the passage of a long time, PCO2 in body fluids may build up to reach toxic levels. The maximum tolerated CO2 buildup is up to an alveolar PCO2 of 80 mmHg, beyond which respiratory acidosis and carbon dioxide narcosis may occur. Now, before going on to nitrogen narcosis, I just want to tell you a few characteristic features of nitrogen as a gas. It passes through cell membranes very slowly, and it is 5 times more soluble in fat than water. And therefore, increased tension of nitrogen can prove to be quite hazardous. Now we know about 4/5 of air is nitrogen. At sea level pressure, the nitrogen has no significant effect on bodily function, but at high pressures, it can cause varying degrees of narcosis. When a diver remains beneath the sea for an hour or more and is breathing compressed air, the depth at which the first symptoms of mild narcosis appear is about 120 feet. At this level, the diver begins to exhibit joviality and to lose many of his or her cares. At 150 to 200 feet, the diver becomes drowsy. At 200 to 250 feet, one's strength wanes considerably, and often the diver becomes too clumsy to perform the work required. Beyond 250 feet, diver usually becomes almost useless as a result of nitrogen narcosis if they remain in the depth for too long. Nitrogen narcosis has characteristics similar to those of alcohol intoxication, and for this reason, it is frequently been called raptures of the depths. The mechanism of narcotic effect is believed to be same as that of most other gas anesthetics. That is, it dissolves in the fatty substances in neuronal membranes, and because of its physical effect on altering ionic conductance through these membranes, it reduces neuronal excitability. Now, bubbles are primarily of nitrogen as the body can manage to get rid of other gases very easily. But when these bubbles are present in fat deposits, they press upon nerves causing sensory and motor disturbances. When they are present in myelin sheaths of sensory nerves, there is disturbance, loss of sensations, paresthesia, itching, etc. When they are present in myelin sheath of motor nerves, there can be motor paralysis temporarily, which is called as diver's palsy. When present in blood capillaries, they try and block these capillaries. In brain, they can occur as sensory and motor disturbances. In lungs, as dyspnea, called as chokes. In heart, as myocardial infarction. And in joints and muscles of limbs, severe pain is caused, called as bends. Now, a word about nitrogen narcosis treatment and prevention. So in some cases, divers make a decision to make a sudden ascent to the surface. What happens in such a situation? There is reduction of pressure suddenly and the dissolved nitrogen comes out in fluid, which forms bubbles in tissues and blood. So the best way to prevent this is to come to the surface slowly. Slow ascent with short stay at regular intervals, that is slow and stepwise ascent, ensures that only a small amount of bubbles are formed at a time. They are eliminated before further ascent. In this way, decompression sickness can be effectively prevented. The second mode of treatment is decompression tank. If the diver is suffering from pain in muscles and joints, they are put into a pressurized tank and then the pressure is gradually lowered back to normal atmospheric pressure. It is even more important as a mode of treatment in people whom symptoms of decompression sickness develop minutes or even hours after they have returned to the surface. In this case, the diver is recompressed immediately to a deep level, then decompression is carried out over a period of several times as long as the usual decompression period. Decompression tank is based on the principle of slow ascent. Usually, no decompression is required after a 30 meters dive for less than 30 minutes. Decompression for a period of 3 hours is required for a 60-minute dive at a depth of 60 meters and a 20-minute dive at a depth of 100 meters. Thirdly, when divers must work at very deep levels, between 250 feet and nearly 1,000 feet, they frequently live in a large compression tank for days or weeks at a time, remaining compressed at a pressure level near that at which they will be working. This keeps the tissues and fluids of the body saturated with the gases to which they will be exposed while diving. Then, when they return to the same tank after working, there are no significant changes in pressure, so that decompression bubbles do not occur. In very deep dives, especially during saturation diving, breathing mixture containing helium and low oxygen concentration is less harmful than natural air because low oxygen concentration prevents occurrence of oxygen toxicity. Helium, when replaced with nitrogen, provides the following advantages. Because of its smaller molecule and lower density than nitrogen, it is easier to breathe. It diffuses faster and is easier to eliminate its bubbles from the body. The amount of helium trapped in the body under high atmospheric pressure is much less than that of nitrogen because its solubility in the body fluids is less than half that of nitrogen. Being less toxic than nitrogen, its narcotic effect is only 1/5. At high pressure, oxygen helium mixture can, however, produce high pressure nervous syndrome (HPNS). This condition is characterized by tremors, drowsiness, and decreased alpha wave activity of electroencephalogram. The cause of this condition is not clearly known, but may be because of other gases like xenon, krypton, argon, and neon. These gases at atmospheric pressure are physiologically inert and have anesthetic effect at high pressure. The anesthetic activity of these gases depends on fat solubility. Now, two physiological problems occur when an individual ascends back to sea level after sufficient exposure to high atmospheric pressure in deep sea. One is decompression sickness and second is air embolism. Decompression sickness or DCS or Benz or Caisson's disease or Dysbarism or diver's palsy occurs in scuba divers or high altitude or even at aerospace events when dissolved gases, mainly nitrogen, come out of solution in bubbles and can affect just about any body area, including joints, lungs, heart, skin, and brain. The symptoms of decompression sickness are caused by gas bubbles blocking many blood vessels in different tissues. At first, only the smallest vessels are blocked by minute bubbles, but as the bubbles coalesce, progressively large vessels are affected. Tissue ischemia and sometimes tissue death are the result. There can be pain in joints and muscles of legs and arms. The joint pain accounts for the term bends that is often used to describe decompression sickness. Sensation of numbness, the chokes. They refer to serious shortness of breath, which is often followed by severe pulmonary edema and occasional death. Paralysis of muscles may occur temporarily due to escape of nitrogen bubbles from myelin sheath of motor nerves. This is called diver's palsy. Coronary ischemia or myocardial infarction may occur due to blockage of coronary capillaries by the nitrogen bubbles. Neurological symptoms like dizziness, paralysis of muscles, collapse, or unconsciousness may occur due to blockage of blood vessels of brain and spinal cord. Treatment is again by tank decompression. Air embolism is air entry into the blood circulation. It's another physiological problem which may occur during rapid ascent from a depth below the sea level. Manifestations of air embolism include chest pain, tachypnea, systemic hypertension, and hypoxemia. In severe cases, air emboli may travel to the systemic circulation and block the blood flow to some vital organs and may even result in death. So the causes can be in case of deep sea divers or Caisson's workers who are breathing oxygen-helium mixture at high pressure, which tries to equal the high pressure on chest wall and abdomen. So when they come on the surface suddenly holding their breath, there is sudden expansion of gases in the lungs, which leads to rupture of pulmonary capillaries. The air enters blood circulation and thus there is air embolism or explosive decompression. Air embolism also occurs in rockets, in which case normally the pressure is maintained according to the height of ascent. But in case there is leakage in a pressurized cabin, there is sudden reduction of pressure. That leads to expansion of gases in lungs, leading to air embolism. Now, what is SCUBA? Self-contained underwater breathing apparatus. So it is a compact arrangement for breathing which the diver can carry with him under the water. In this apparatus, the air is compressed so that more air is carried in less volume and also the gas amounts to a substantial quantity even when the ambient pressure is high. So it comprises of a cylinder of compressed air connected via mask and tube for breathing through a valve. The valve permits appropriate amount of compressed air to be delivered to the diver and expired air is released into the surrounding water. So deeper and longer dives can be made safe by using SCUBA. So now at the end of this lecture, I want to leave you with some important questions that often come in exams. So acclimatization is a very important topic which can come as a short note or even a long question. The other topics usually come as short notes. for example, on safe zone, critical altitude, then effects of high altitude during rapid and slow ascent, which will include high altitude pulmonary edema, high altitude cerebral edema, and of course, mountain sickness, acute or chronic, SCUBA, also short notes on bends, chokes, diver's palsy, and a note on decompression sickness. Thank you and have a good day.